Lower lid hollow and rounded. Would AlloDerm give good results? I'm in my late 60s and have hollows in my lower eyelids and some rounding due to a previous surgery that was done many years ago. The doctor has since retired. I'm interested to know, would AlloDerm or similar and fat transfer give a good result? Would an oculoplastic surgery do both AlloDerm and fat transfer, or would I need to go to a different doctor for each procedure?
Thank you for your question. You've submitted a question with photos showing a rounding of your lower eyelids, and clearly you've done some research because you're asking about the benefit of AlloDerm and fat transfer, and would an oculoplastic surgeon be able to do both, or will you need separate surgeons? Well, I'll help you understand the basis for your situation and give you an idea of my approach. I happen to be an oculofacial plastic surgeon practicing for about 20 years. I'm also boarded in facial cosmetic surgery as well as body, breast, and extremity surgery. So I do everything head to toe, including hair restoration. So with no limitations in my scope of surgical procedures, I can share with you the different things that I've done to help my patients who come to us with what you have, which is essentially something called lower eyelid retraction. To understand the lower eyelid, you basically have to get an idea of what it takes to support a lower eyelid before you start asking questions about materials. So, there are essentially three components to lower eyelid position. One is the lateral canthal tendon. Now, the lateral canthal tendon is the attachment of a very important connection between the lower eyelid and the bone of the orbital rim. The second part is the support, the internal support of the lower eyelid, which is like pillars. And these pillars, these vertical pillars or support underneath the eyelid, behind the eyelid, is referred to as the posterior middle lamella. And that's where the AlloDerm question comes up. Then the next part of this is, of course, the skin, the amount of skin that you have available to physically move upward. You see, a lot of people who come to us have had too much skin removed from their lower eyelid, resulting in a combination of eyelid retraction or a rotation of the eyelid away from the eye called ectropion. So when someone comes to me, I'll do an assessment to evaluate all of those factors. Do they have enough skin? Do they have support in the lower eyelid? How far is their eye projected? Because that's also an important factor in the dynamics and the physics of the way the lower eyelid is positioned. And of course, the strength and the position of the lateral canthal tendon. Now, in my practice, what we have been typically doing, and I have experience with the posterior or middle lamellar grafts, such as hard palate mucosa, AlloDerm, and what we have been doing mostly in our practice for the past couple of years is using a material called Enduragen. Enduragen is a material that is derived from pig dermis. Now, this doesn't mean that AlloDerm is not an acceptable choice. Every surgeon has their own ideal way of combining the procedures and materials in their hands and what works for them. So I think that what you're describing is really the scope of an oculofacial plastic surgeon. This is an area where when plastic surgeons, facial plastic surgeons, or anyone else who does blepharoplasty, when they have complications, they will ultimately need an oculofacial plastic surgeon. But what is important is a proper physical examination to make that determination. Now, to discuss the other option that you were discussing about fat transfer, there is a role of fat transfer, but in my experience and in my approach, I don't do fat transfer as part of the first primary procedure, which is to restore the anatomy. That's a critically important factor, is that lower eyelid position is very important for proper eye function. And when you have this bowed eyelid and you have this detachment or stretching of the lateral canthal tendon, your your tear film is not going to be properly distributed and you're not going to have good ocular health. So first I would reposition the lower eyelid into its proper anatomical position. Now, because this is a more advanced and complex procedure and there's grafting involved, there is a time frame where you're going to have to kind of watch how things heal over several months. So typically I would do this as a staged procedure. Now, if fat transfer was indicated, then I would do the fat transfer, and with all these procedures, we have also added some additional adjuvant therapies, such as the use of platelet-rich plasma, extracellular matrix for improvement of wound healing, and this is the type of procedure that requires a lot of initial care after the surgery. So at this point, it is probably best for you to meet with several oculofacial plastic surgeons and get some opinions as to what would be their approach and why, and then move forward with choosing one that you are comfortable with. So in summary, we're talking about several factors such as the lateral canthal tendon, the posterior lamella or the middle lamella support, and the anterior lamella or skin. So a proper physical examination is necessary before you make a decision about what materials to choose to have you get the best result possible. So I wish you the best of luck. I hope that was helpful, and thank you for your question.